So if all else fails and the child is left in respiratory distress, that will bring us to this next subject, which is respiratory arrest completely. And respiratory arrest, remember, is when the patient has a pulse but no respirations. Remember, advanced life support starts with excellent BLS. And if you believe your patient is unresponsive, then start by tapping and shouting to verify. If your patient is unresponsive, call for advanced care and assistance. In a hospital setting, this might include calling a medical code. Make sure to follow your local protocol and make sure that the certain ways that your team have practiced the code are followed. Obviously, these emergency response team codes are being worked on so that we have the most efficient team efforts in completing good resuscitative care. And in the pediatric patient, so that we don't allow respiratory arrest to quickly go into the ultimate arrest, cardiac arrest. But in a pre-hospital setting, this may include getting assistance from another advanced life support. We call those ALS units. Maybe it's a higher level of transportation, especially in certain communities where they use a basic life support ambulance that's intercepted with advanced life support. Next, we're going to assess circulation and breathing by checking for a pulse. If it's on a child, it's going to be a carotid pulse. If it's on an infant, it's the brachial pulse. We want to look at the face and chest at this time for signs of breathing. For a patient in respiratory arrest, we would find there is a pulse, but there's no adequate breathing. Remember that agonal respirations or snoring respirations do not qualify as effective breathing. So now that we've decided to give rescue breathing, we should open the airway with a head tilt chin lift. A folded towel or maybe even a diaper placed under the infant's shoulders could help with the correct positioning in order to keep the airway open, yet not hyperextend the neck. Placing a basic airway can help to keep the tongue out of the back of the throat and help ensure ventilations are successful. An oropharyngeal airway, or OPA for short, would be measured by placing it alongside the patient's face, from the corner of the mouth to the lower tip of the ear. If the OPA is longer than this area or too big, it could actually cause a blockage and defeat the purpose. In addition, we will always check to see if there's a gag reflex before attempting to place an OPA. If there is a gag reflex, don't attempt an OPA, as this can cause vomiting, which may just complicate the airway management and oxygenation. Now at this point, we need to deliver one breath every 3 seconds for a child or infant. This would be about 20 breaths per minute. Breaths should be given with a bag valve mask at 15 liters per minute of oxygen. After rescue breathing has begun, a heart monitor should be attached and vitals assessed with oxygen saturation, the blood pressure, and a pulse. As breaths are being delivered, it's important to monitor their effectiveness. This can be done by watching for good chest rise and fall, and if the patient is intubated, monitoring capnography and avoiding gastric inflation will be achievable. This is why our next action should be placing an advanced airway and gaining IV or IO access. Remember, if the pulse rate drops below 60 beats per minute, start compressions. Also, let's remember to look for and treat underlying causes of the respiratory arrest all along the path to successful resuscitation.